This is Dr. Janice Williams, and I will be lecturing on HIV and AIDS, also known as the human immunodeficiency virus and the acquired immunodeficiency syndrome. We will talk about that further as we go through this lecture. I will be giving you an overview of this disease process. This is not intended to be a lecture that is all comprehensive. You will see throughout the lecture that there are reference points where if you would like to get more detailed information about any component of this disease, I have included links for you so that you can do that. First, let's talk about the objectives that will be covered during this lecture. We will be looking at some of the epidemiology of this virus and how it has transitioned over the years. You will also and should be able to demonstrate your knowledge of the HIV virus, the pathogenesis, the transmission, and even some of the treatment modalities. After this lecture, you should be also able to see how science is evolving around this virus and where our future efforts are being focused related to this virus and treatment. What I would like to highlight about this slide, looking at the global impact of the HIV epidemic in 2019, is that we are seeing that the number of individuals living with HIV is increasing. And yet we also see that the number of individuals dying from HIV is decreasing. This is related to the improved treatment modalities we now have for HIV patients, which includes not only the medications, but the preventative measures that we have implemented within this disease process. Also, it is important to note that the newly infected individuals who have been diagnosed with HIV is also, although it is lower than where it used to be, like in 2017, it is still increasing. And it is very important to note the populations that are at highest risk for either living with this disease and contracting this disease and even dying from it. So those healthcare disparities still exist. So if you look at the slide, what you'll see is that adults, heterosexual couples, are still being impacted by this disease process, and women are being impacted more than men. We do still have a percentage of young adults that are still being impacted, despite many of the options that now exist that prevents and almost reduces the transmission of maternal to child transmission of HIV. So let's talk about also how the profile of individuals who are newly infected with HIV, what that looks like. So if you look at this slide again, what it shows is that there is still a disproportionately higher number of African American men who are gay and bisexual who are contracting this virus. And then next it goes to Latino gay and bisexual men, and then white gay and bisexual men. And then the next category goes to, again, our African American heterosexual women. And then you can go down and see how the other statistics go. This is very, very important because as we start to talk about what treatments are out there, what options are out there, I want you also to start to think about, why do you think that we have this disparity within a disease process where there is increased access to care for some, and we have such good treatments that can markedly improve the outcomes for anyone who may utilize them? So I just want you to think about that as we go through this lecture, because I think it's very, very important to note that we can have some of the best treatments out there, but if it's not distributed equitably then we need to start to look at that as providers and see what we can do to improve outcomes when we have such good resources. And I will not spend a lot of time on the next few slides, but I just want to really make it very clear how important it is for us to recognize, no matter where you are, no matter where you're practicing, the importance of looking at what population is impacted by disease processes, which will help us to be better practitioners. So from this slide, what you can see is the age group, which is 25 to 34, our highest of individuals with newly diagnosed HIV. And please note, this is newly diagnosed. We're not talking about those who are living with, we're talking about newly diagnosed HIV. And again, this is just giving you more of the data in just a different format for you. But I really think this is very important for us to note. And then on this slide, what I want you to see is that when we talk about the lifetime risk of individuals who may contract HIV, then you can see what becomes, I believe, evident is which areas are more condensed with having a risk of getting HIV. This becomes very important, again, for us as practitioners, depending on where you're practicing, is to know what are the risks out there for your patients. So you will know how to take care of them and what preventative actions to offer, or even just to be aware of what may be going on in the community in which you are going to be practicing. This slide is just to give you a little taste of the evolution of HIV over the years. So as you all may know, HIV was identified in the late 1980s. The identification of AIDS, however, was in the early 1980s, like in 1981. The difference between AIDS and HIV is the opportunistic infections that the individuals experience. So when individuals started presenting with these AIDS, these acquired immunodeficiency virus syndrome, that is what was identified first, and then HIV. And then in 1986, HIV-2 was identified. So there are two strains of HIV, HIV-1 and HIV-2. In 1993, it was important that legislations were starting to be passed that would define what services individuals with AIDS or HIV could receive. But what was really paramount was the CDC's definition of AIDS was approved. And that definition basically said that anyone who had the HIV virus and who had a CD4 count less than 200 was considered to have AIDS. In 1995, the improvement came with the approval by the FDA for protease inhibitors. And this was important because what it did was it changed the care that was given to individuals who were infected with HIV. It allowed them to have a medication that we saw that was really potent and promising in the effect that it was not impacted by the resistance that this virus could have to other medications. And then in 2007 and in 2019, the only two individuals that have been known to be cured of HIV were identified. And both of these individuals were cancer patients who had to receive a bone marrow transplant. And they both have undetectable, no detection of the HIV virus anywhere in their blood. I just think that's a neat fact. Here, what I want you to see is, and give you a little more information about the difference between HIV-1 virus and HIV-2. HIV-1 virus is the virus that we mostly see here in the United States. And you can also see it in like Europe and Australia. Um, Whereas HIV-2, it originated in West Africa. You can see that virus. Sometimes you'll see it with individuals who are infected who live in like Spain, Portugal, and also even France. The big piece or difference between HIV-1 and HIV-2 is HIV-1 virus. Um, Oftentimes, individuals affected with that virus, the progression of that virus can lead to AIDS. It also, we see in these patients, these are the patients that can get the high viral loads, the low CD4 counts. Whereas HIV-2 is those patients or individuals do not get as sick with their virus. They may not even need medications. Here is just a little more detail about the difference between the HIV-1 and HIV-2. I know you all will get a more information in a lecture on the pharmacology of the heart therapy. However, I included this slide for you because even as we talk about the way the virus attacks our cells, it's also important for you all to know that the medications that are being developed and being researched looks at this genomic mapping to try to see how we can combat and reduce the impact of this virus on the body. Now that we've reviewed some background related to the HIV virus, let's now take a look at what is the human immunodeficiency virus. Let's talk about that. So the human immunodeficiency virus, also known as AIDS, it's an acquired disorder that occurs by causing a dysfunction in the immune system of its host. This virus can be caused by HIV-1 or HIV-2. It is important to note that this is a retrovirus. That means it has two single-stranded RNAs. It is not a DNA virus, it's an RNA virus. And with the HIV type 1 and type 2, they decrease the CD4 and the T helper lymphocytes. Those are the main targets of the HIV virus. However, the HIV virus also targets like dendritic cells, macrophages, also trying to cause destruction. But the main destruction occurs in the CD4 and the T helper cells. So with that, how is this virus transmitted? There are 3 modes of transmission with this virus: sexual, perennial, and perinatal. Sexual is through the semen, the vagina, and the cervical secretions. Perennial is the blood products, contaminated needles and syringes. And then perinatal is in your utero during delivery or breast milk. What we are seeing is we have reduced dramatically the transmission of HIV parentally and perinatally. However, it is still being transmitted sexually. And where the research is now is if a mother is HIV positive, if she's taken her medications, she can deliver an HIV negative child. We also are at a point where you can have an HIV positive couple who wants to have a child. They can successfully have an HIV negative child. So there are many options out there for the reduction of the transmission of HIV. However, we're still seeing new cases. And remember that question I asked you, why do you think we're still seeing these cases? What can we do to reduce that? I would like to bring that question back to you now, because if you look at it, we still are seeing the transmission of HIV. And if you remember back to our epidemiological slides, heterosexual couples We're also seeing it with MSMs. So it's sexually still being transmitted. Um, it's the primary way of its transmission. So, thus, what can we do to reduce that, even as primary care providers, even as nurses or as educators? What can we do, if anything? Because we have great treatments out there. If we can have parents who are HIV positive, have HIV negative children, we know that the therapies work. The question is, why is not everyone on therapy? So we've talked about the transmission of HIV, the three modes of transmission. So now let's talk a little bit about the structure. I think that becomes important. We know that we have this virus. The question is, how does this virus get transmitted? A big piece of that is the structure of the virus itself. So let's talk about the structure of the HIV virus. Now, the HIV virus, the virion is what they call it, consists of a core, and it has two identical strands of viral RNA molecules. It also has three viral enzymes: integrase, protease, and reverse transcriptase. They're all within that capsid. Remember those words: integrase, protease, and reverse transcriptase. Those will come into play when we talk about how this virus actually infects the host. But it also becomes important, and you'll see this when you get your lecture in pharmacology, of the medications that we use to try to combat the virus taking over the host. Now, that's the inner capsid, but on the outer surface, you have this envelope of the plasma membrane where you have the budding of the cells that will occur. And what you have is you have these glycoproteins that stick off of this virus, the structure. And those glycoproteins, which we know of as GP120 and GP41, these are necessary in the attachment of this virus to its host. I want you to remember this as well, because that GP120 and GP41, when we think about the HIV test that we run, this is what we're looking for. Kind of like when you're looking for like Lyme disease and you're trying to look for all of these different identifiers, and you got to have the identifiers to say that someone is positive for Lyme's disease. This is similar to HIV. When we do our HIV test, these are the glycoproteins that they're looking for. So this structure of this virus is important to know, because it helps you also understand how the medications that we use, the antiretrovirals, how they impact the virus and its progression. So let's talk about, now we've talked about the structure of the virus. Let's talk about the life cycle of the virus. How does this virus infect its host? There are 7 stages that's important for you to know. It does it by binding, entering, reverse transcription, integration, replication, some say it's transcription or translation, assembly, and budding. So I want to talk about those. As you look at your slide, on the right hand side, what you're going to see is I tried to parallel for you the pharmacology so you can kind of understand how the medicines and where those medicines work compared to how the virus infects the body. So the treatment for HIV specifically works to combat the virus being able to replicate itself by breaking down its ability at some stage within its process. So let's start by talking about the first stage, which is binding. So remember we talked about those glycoproteins that's on the core of the HIV virus itself. So those glycoproteins have to bind to the receptors on the transmembrane of the CD4 cell. That's the first step. Then once they bind to the CD4 cell, they then have to enter the HIV virus, has to attach to the CD4 receptor, and they use what we call the CCR5 and the CCR4 receptors. And they are located on the surface of the virus. And then what they do is they bind to it, and then the virus fuses itself into the host cell so it can release its enzymes. Once it does that, the third stage is that it does exactly what the name says, reverse transcription. What the virus then does is that it has to then convert its RNA into DNA. And then it then moves to its integration phase, which is when that newly developed HIV DNA enters the nucleus of the CD4 cell. And then where the integrase, and it inserts itself into the DNA of the human, of the host of that CD4 cell. It can either remain there dormant, or it can create new virus, which can activate the CD4 cells. The next step is the transcription or the translation. And what happens in this phase, phase 5 or stage 5, is when the HIV DNA is transcribed into RNA and then is translated into HIV proteins. And then after it does that, it assembles, where the HIV virus then brings it back together. The protease has to cut it into chains so that it can now assemble into smaller individual proteins. And then it can be copied. And then the last step is that it will bud, okay? That newly formed virus. What I want you to see is when we talk about this process, if you need a visual that's a little more easier to understand, please go to your textbook on page 313. And what it'll do is it'll show you that whole process. But it has to go through each one of these phases in order for the virus to infect its host and then be able to replicate itself. Now, although it has the 7 stages, one of the things about the HIV virus, it replicates very, very quickly. So with that, what I like to say is it doesn't always, it's not error, it's error prone. And I think Dr. Seibert talked to you about that. When you're replicating so fast, there are good chances that you're going to have a mutation because you're not going to be able to replicate exactly the same every time at such a high rate. And that's what the HIV virus does. It replicates so fast. And because it replicates so fast, one of the challenges we have in HIV care is that there's this, what we like to call mutations or that can occur with this virus. So although we're treating the virus and it's effective with the medications, there's this little mutation that can occur that prevents the medication from eradicating all of the virus in the body. This is also one of the challenges we face with this virus, because what can happen is individuals who are on medications, if they stop the medication, that virus that's sitting in those tissues and kind of have a different mutation can then resurface. That's why it's also important, as we talk about treatments, which you'll learn in your pharmacology class, that patients stay on this medication. And is often why we can suppress the virus, but we can't cure the virus, because there's this, what we call this quasi-species, that the virus looks similar to what we know we're treating, but is not exactly the same. Just some information about the HIV virus that I think is important for you to know is to remember is, one, although the main impact of HIV is on the CD4 and the helper T cells, do know that it can target the macrophages. It can target dendritic cells. And it also can sit in the lymph lymph nodes and lymphatic part of the body. So that's very important to know about this HIV virus. So it's not just that it's a CD4, but it is the other areas as well. What we are finding out now in research, and this has been some of the newer knowledge, is that before we thought that the HIV virus, because it causes or leads to apoptosis, is that it was all reflective of the virus. But what we are now finding out is that apoptosis is not always the virus. It is kind of like a trigger. It's causing the apoptosis in other cells, although that cell doesn't have to be infected with the HIV virus, which is another challenge that and where research is starting to focus on is how do we reduce this apoptosis that occurs in unaffected cells of individuals who have HIV. Another point I wanted to make sure that I highlight too is that the thing about HIV virus, it is an inflammatory disease process. So once inflammation starts, even with patients who are on therapies, the inflammation is always there. So thus leading to other complications that may occur in HIV patients that we are now starting to have to address because of the long-term inflammation that these patients may have, even despite being on treatment. And again, just to reiterate a little bit more about the HIV virus is, I think I mentioned earlier about how fast the HIV virus replicates itself. And knowing that this virus also sits in the GI tract as well. And we can normally see that within the initial 3 to 6 weeks. So think about some of the symptoms that you may hear patients have with HIV, like diarrhea, flu-like symptoms, and things of that nature. That's all part of this inflammation process and the pathogenesis that occurs with this HIV virus. So now that we've talked about the structure of the HIV virus, we've talked about the life cycle of the HIV virus, why are we so concerned? What makes this virus of concern is not only the inflammation that it chronically puts the host in the body in a state of chronic inflammation and the complications of that, but also the damage that occurs to the cells and the immunocompromised state that opens up the host to a numerous amount of infections that can be deadly. So the whole goal is to reduce that from happening. So now that we've talked about that, one of the things I would like to do next is I want to now talk about what happens if an individual is infected with HIV. What does that look like clinically? So what it'll look like is you have what we call acute infection or chronic. And we will see a difference in the patient's labs and sometimes even their presentation. It will also show differently on when we do testing. When you test a patient who has HIV and they are recently infected, then what we'll see is we can detect that virus as early as 10 days in acute infection. But that detection has to be with a test that is called the nucleic acid test. So we're going in specifically looking for the virus. When you're talking about detecting the antibodies to the virus, we have gotten to where we can detect in some patients as early as 7 to 10 days with an antibody test. Sometimes the question comes up, you test the individual for HIV, you believe they've been exposed, but their antibody test comes back negative. What do you do? In order to capture them during an acute phase, you would have to run an HIV nucleic test looking for the virus itself. We call it a viral load test. One of the reasons we do not automatically run a viral load test is the cost of that test to be drawn. Also, If a patient presents during the acute phase, there are symptoms that we can look for and discuss with the patient that can be an indicator that they may have been exposed to the HIV virus. And we'll talk about that a little bit. What I like to do here is just talk a little bit about what happens in the progression of HIV for an individual who does not do any type of treatment. I want to talk about this because it becomes important when we look at where we are now with how we treat HIV patients. So if you look at these slides, what it's basically telling you is that we can identify HIV within the first few weeks of being infected. And we call that the acute phase. And during that acute phase or acute HIV syndrome phase, what we see is the patient's CD4 count will dramatically drop and the viral load will dramatically increase. And then what we also have is we have the progressive infection of our mucosal T cells, dendritic cells, propagates, and it will spread through the lymphatic organs. And then that virus will just keep replicating, and circulating, and then decreasing the CD4 counts even further. And then once that is complete, we will then hit about, I guess, 8 weeks, we will hit what they call clinical latency. So what happens is if you get a patient during the clinical latency stage, this is the stage where their CD4 has kind of leveled off. The viral load even starts to come down. So they look almost normal during that time. They can stay in that clinical latency stage for about 5 to 10 years. And then after that time frame, for the next, if they do not take medications, 5 to 10 years, they're still having destruction. They can still transmit this virus. But it is projected that if they do not take medications, if they do not start heart therapy, within 2 years after that, they will pass away. So with that knowledge, it has increased or contributed to the recommendation that all patients be offered heart therapy at initial diagnosis. I put this slide up here to help you understand that there is staging for the HIV virus for patients, and you have to know which stage your patient is in. The take-home point from this slide is if a patient is in stage 3, that is what we consider AIDS, acquired immunodeficiency disease syndrome. They have AIDS. And the reason they have that AIDS is because their CD4 count is less than 200 and they're presenting with an opportunistic infection. Opportunistic infections include things like pneumocystic pneumonia. It can be candidiasis, thrush. It can be cytomegalovirus. It can be any of those diseases. But what's important to know is if a patient was ever diagnosed with AIDS, say they didn't know they had HIV or they refused to have treatment, their CD4 count went below 200, they decided to come in and get treatment. When they came originally to you, their CD4 count was less than 200, you would then have to diagnose them with the diagnosis of AIDS. If you put them on treatment, their CD4 count went up. They have no more opportunistic infections. For the rest of their life, they are still categorized as having AIDS. According to the CDC, you can never again put a diagnosis of HIV. They should always have the diagnosis of AIDS. When we talk about treatment and prevention in regards to HIV, the treatment we currently use for HIV patients is considered heart therapy. That stands for highly active antiretroviral therapy. For HIV patients who are on heart therapy, the medication that they take is determined by their virus and other health characteristics. So different patients can be on different regimens. Those regimens can consist of one pill a day or multiple pills a day. You will learn more about the pharmacology aspect of the treatment of HIV in your pharmacology course. So I will not go into any further detail regarding the pharmacology for HIV treatment. It is also important to note that when we talk about treatment, prevention is a big part of treatment with HIV. Educating the HIV patient about how they can reduce the spread of this virus to others is very important, as well as educating individuals who may have risk factors for contracting HIV, how they can reduce that risk, and maybe even recommending a treatment that we have available called PrEP, which I'm quite sure you will also learn about in your pharmacology course. Now, I mentioned briefly in the previous slide about heart therapy. Here, I just want you to see that this is how and why heart therapy is so effective. The medications that we utilize to treat these patients are aimed at targeting the HIV virus at some aspect of its life cycle. And when and if we are able to do that effectively, then we can suppress the virus. I would like to conclude this lecture with just giving you some resources that you can access through the internet that will keep you informed with the latest information about HIV and different treatments. Also on this slide, you'll see that there is information or a link to a website called Infectious Disease Society of America, IDSA. This is a wonderful site because it not only can give you information about HIV and AIDS, but it can give you information about a lot of infectious disease processes. It'll inform you about the guidelines. It just has a plethora of information of diverse diseases. So this concludes my lecture on HIV and AIDS. Please refer to your textbook for supplementary information, and I hope you enjoyed this lecture.